Hello, Devanjan sir, Dhritiman sir, Jayati ma'am. My name is Himanshu. I'm from AstraZeneca. Very pleased to meet you.
Hello, we are honored to be here.
Hello, Vidya ma'am.
Hi, Himanshu.
Hello, ma'am.
Dr. Himanshu, shall we start the session, sir, so that Dr. Amit will join shortly?
Yeah, sure.
Yes, sir. Yes. Good evening, everyone. On behalf of the International Association for Integrated Oncology, it gives me immense pleasure to welcome you all to IAIO Expert Insights on Breast Cancer. We are delighted to have such a distinguished panel of oncologists, pathologists, and experts joining us today for an insightful discussion focusing on the evolving HER2 spectrum in breast cancer, particularly HER2 low and HER2 ultra low disease. Before we proceed, I would like to extend our sincere gratitude to our supporting partners, AstraZeneca, Sun Pharma, and NATCO, for their continued support in advancing oncology education and scientific exchange. Thank you for partnering with IAIO in today's knowledge-driven initiative. To begin the evening proceedings, I would like to invite Dr. Himanshu Ajay Tillu, a diagnostic manager at AstraZeneca, to set the context for today's discussion. Sir, over to you, please.
Yeah, thank you, Rukmini. I'll be sharing my screen, so please let me know once it's visible.
Yes, sir. Sure, sir. Sure. Yes, sir, it's visible.
Is it? It's okay. Thank you so much.
Thank you, sir.
Okay. Good evening and warm welcome to everyone. Thank you, IAIO, for giving me this opportunity to set the context for what promises to be a scientific feast for today. Greetings and a warm welcome to all the eminent faculty who have taken time out and who have come here to share their expert insights with us. And a big thanks to all the audience as well. So, HER2 testing in breast cancer is actually entrenched in oncology community. It's being practiced since decades. So then what has changed? Why are we having this meeting? So historically speaking, while HER2 was reported in a binary fashion as HER2 positive versus negative, and HER2 positive being the actionable category. In the last few years, this has undergone change. And the negative HER2 negative category, which was not actionable more or less, is now basically subdivided into two new categories called as HER2 low and ultra low, which are now actionable with TDXT. So what these trials have done is that they have extended the benefit of targeted therapy to a large proportion of previously ineligible patients. This has resulted in actual complete change of HER2 classification with a lot of new categories that have come up, and it has actually made the situation a little complex. Now, the actual challenge is to be able to pick lower expression levels of HER2, which is basically HER2 low and especially HER2 ultra low, with clinically validated assays that were basically devised and validated to pick up on higher expression levels or HER2 overexpression. So with those assays picking up lower expression of HER2 is a challenge, and there are several publications which highlight this particular point. As you go down the expression level of HER2, at those levels, the variability and the subjectivity amongst pathologists to actually identify HER2 low and ultra low actually goes up. This situation is further complicated by a lot of non-specific HER2 staining patterns as well. Moreover, although for the assay 4B5 and with Ventana has been accrued the CDX status, however, in India, we observed that there is a lot of fragmentation and variability in terms of assays that are used for HER2 staining. This also has an impact on the selection of patients for the suitable targeted therapies. Now, AI is getting in everywhere, and pathology is no exception. And there are also a lot of publications which have actually shown how AI can actually improve the identification of HER2 ultra low breast cancer by helping pathologists to basically differentiate IHC 0, that is IHC null, IHC 0 plus, that is ultra low, and IHC 1 plus. CAP has in the year 2025, College of American Pathologists have published 2 reporting templates in rapid succession, and they have introduced quite a lot of changes and recommendations for certain things to be included on the report, such as the percentage of staining intensity. They have introduced a new category, IHC 0 plus, to define HER2 ultra low, degree of HER2 heterogeneity, so on and so forth. Now, the focus now is basically that the treating physicians need to understand the definition of HER2 ultra low breast cancer, and the pathologists need to help them by reporting HER2 ultra low breast cancer in adherence to ASCO and CAP reporting templates. And it is around all these things that we have discussed so far that our eminent speakers today are going to take us through and share their insights with us. So today, after this, Dr. Amit will take us through the treatment landscape across the entire HER2 spectrum in breast cancer. Then there will be a session by Dr. Indu Arun, who will take us through the HER2 ultra low, which is the current hot cake. And then there will be a very engaging panel discussion on the same topic, moderated by Dr. Dev Malya. And we have our honored panelists, Dr. Rakesh, Dr. Jayati, Dr. Arpan, Dr. Rajiv, Dr. Dhritiman, and Dr. Debanjan. With this, I will stop here and hand it back to you, Rukmini. Thank you so much.
Thank you, Dr. Himanshu, for the insightful opening. We now move to our first scientific talk of the evening. I'm pleased to invite Dr. Amit Tatwari, a leading consultant at Apollo Cancer Center, Kolkata. Dr. Amit will be speaking on treatment landscape of HER2 spectrum in breast cancer. Sir, over to you, please.
Yes, well, I hope my slides are visible.
Yes, sir, it is
Is it?
visible.
So thank you, AstraZeneca, and thank you, IAIO, for giving me this opportunity to discuss this very important topic, which is treatment landscape of HER2 spectrum, MBC. Yeah, so we'll try to run you through important trials and what is important and new developments which has happened over here. Now, so if you see invasive breast cancer by molecular subtype, they are either HER2 positive and hormone positive and HER2 negative, or hormone negative type, or you can have both negative, which means hormone receptor negative and HER2 negative, or you can have hormone receptor positive and HER2 negative. And they all have different biology. So those who are hormone receptor positive and HER2 positive, their characteristic is that they are high grade tumor with a poorer survival, with a high Ki67 expression. And those who are hormone receptor negative but HER2 positive, they are also fast growing tumor with more aggressive phenotype. And those who are hormone receptor positive and HER2 negative, they are actually slow growing tumor with less aggressive phenotype, and they usually have a better prognosis. And those who are triple negative, they are usually younger female, they have a poor outcome, and they do metastasize faster, and they are usually not responsive to hormone treatment or HER2 targeted treatment. Now, in first line MBC, the standard of care was set up by Cleopatra trial, and that proved that when you give trastuzumab plus pertuzumab plus taxane, the median PFS jumped from few months to 18.7 months, and because of that, this became a standard of care. Then once the disease progresses on this type of regimen, we had TDM1, which was established by two trials, Emilia trial and Catherine trial, these two trials. And that also suggested a MPFS, PFS advantage was better. And in this trial, Emilia trial, the median PFS was 9.6 months. In the K2 trial, it was approximately 6.8 months. And this is also real world. There are a couple of real world studies which says that PFS with this TDM1 is approximately 6 to 7 months time. So we do have in MBC Cleopatra regimen, which is the approved first line treatment. And then we do have a TDXD based on the Destiny 03 trial, which suggested that the PFS was tripled in this trial, and which has essentially replaced TDM1 as the second line choice. So we'll discuss this Destiny Breast 03 trial. And in this trial, you see that the median PFS is 25.1 month, favoring TDXT compared to 7.2 months for TDM1. And 12-month PFS are also like 76% versus 35%. And the Kaplan-Meier curves are widely separated from each other, telling you that there is a benefit of doing TDXD type of regimen compared to TDM1. And based on this, the TDXT has replaced actually TDM1 in the second line setting. And they have TDM1 has actually moved to now third line setting. So now first line setting is like trastuzumab, pertuzumab, and taxane based on Cleopatra, and TDX2 based on is a second line treatment based on Destiny Breast 03 trial, and TDM1 is third line treatment. So, but the problem is that, say if we are talking of HER2 positive disease, which is 70%, only 10 to 15%, or in some studies 20% of them are HER2 positive. So where we practice what I just spoke about. But what about those cases who are actually HER2 negative, and they are in this subgroup 85%? So usually standard of treatment used to be hormonal treatment plus minus CDK4/6 inhibitor, and when they will progress, maybe you have Aplacib like regimen, and then you had a chemotherapy. And if we talk of hormone receptor negative, which are approximately 30% of the total chunk, then HER2 positivity in the subgroup is even low. It is just 5%. And those who are HER2 negative, which is majority of them, the treatment of choice used to be only chemotherapy. So there is a great unmet need here in both hormone receptor positive and hormone receptor negative cases, particularly when we talk of earlier way of classifying HER2 as positive or negative. So what is new here is, as the previous speaker before me highlighted, the concept of HER2/neu low and HER2/neu ultra low, which has changed the management paradigm in this set of the patient. So earlier it used to be HER2/neu was positive when it was 3+, where there was intense complete staining in more than 10% of tumor cell, or when it was 2+, which is weak or moderate complete staining in more than 10% of tumor cell. They were classified as equivocal. You do FISH if positive, then you club them as a HER2/neu positive tumor, and 0 and 1+ were classified as HER2/neu negative classically. But now there is a change with them. There is a 2 category out of this, HER2/neu low and HER2/neu ultra low. So HER2/neu low is proposed as when the IC score is 1+, or if it is 2+ and FISH negative. And evidence were insufficient actually in defining this HER2/neu expressing breast cancer as individual subtype. So now we will discuss Destiny-04. What was the study design and study result? So this was open label randomized phase 3 trial in HER2/neu low subgroup of unresectable or metastatic breast cancer who has already received prior 1 to 2 lines of chemotherapy in metastatic setting. HER2/neu positive, hormone receptor positive disease were enrolled, but they have to have endocrine refractory, and they were randomized into 2:1 ratio to TDXD in the standard doses to treatment of physician's choice. It could be capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. Primary endpoint of this trial was blinded independent committee review PFS, and there were a couple of secondary endpoints. For the paucity of time, because I have been given 15 minutes, we'll go directly to the result. So if you see the PFS in hormone receptor positive disease, it was bettered by approximately 2 times. So hello. Yeah. So 5.4 months in the physician's choice treatment arm versus 10.1 month in the TDXT arm. And when you see in the group here, then you see that in all comers, it was 9.9 versus 5.1 months. So, and both these curves were positive for statistically, with the hazard ratio being close to 0.5 in either group. And when you see OS, the OS data also favored TDXT in both hormone receptor positive cases and TDA, all comers, which is the intention to treat analysis. So it was 24 months versus 17.6 months, and here 23 months versus 17 months. So the crux or the message from this slide is that in hormone receptor positive cohort and in all patient cohort, median OS demonstrated 31% reduction in the risk of death for patient receiving TDXT compared to those receiving physician's choice treatment. Now, when you see the efficacy of in hormone receptor negative cohort about OS, this was like doubled, 17.1 months versus 8.3 months. But let me remind you, there were less number of patients in this cohort, and also the PFS was approximately 2 times more. And the hazard ratio for OS was 0.58 and the PFS was 0.29. So this also tells you that here in this hormone receptor negative group, 42% reduction in the death happened and 71% relative reduction in the risk of disease progression or death happened when TDXT was used compared to when TDXT was not used. So now this has opened the box little bit further, and more number of patients can be treated by TDXT. So initially, hormone positive group, it was only 15%. But now we know that the horizon has got widened because HER2/neu low is seen in approximately 55 to 60% of the patient. So approximately 75% of them are either HER2/neu positive or HER2/neu low. In hormone receptor negative cases also, since they were only 5%, now total 45% of the patient, they do become eligible because of this 40% discovery of HER2/neu low category in this subgroup. This is it. So for this subgroup earlier, in HER2/neu low subgroup, actually conventional anti-HER2/neu treatment were not applicable because they were ineffective. So actually prior to Destiny-Breast04, there were no approved HER2/neu targeted therapies for treatment of HER2/neu low MBC. Therefore, it's essential that we do catch this lower level of HER2/neu expression which can be clinically relevant. And based on the efficacy demonstrated by Destiny 04, it is now important to accurately identify a patient with HER2-neu low MBC who may benefit from TDXT. With the approval of TDXT in patients with HER2-neu low breast cancer, there is also need to more closely evaluate HER2-neu IC staining in order to accurately identify patients in this new actionable population who may be eligible for HER2-neu targeted treatment. And that's why it's vital that more and more pathologists, they do adopt this newer way of classifying HER2-neu. And I'm happy to tell you that majority of the centers, it's already happening. Now, there's all the guidelines, major guidelines, they do have incorporated this HER2-neu low, be it ESMO or the ESCO CAP guideline. So because of this updated knowledge, there is a new indication of trastuzumab deruxtecan when HER2-neu is not overexpressed or amplified, but IHC is 1+ or 2+, but FISH negativity. So now we'll try to understand role of TDXD in both low and ultra low subgroup of HER2-neu positivity. So now this ultra low subgroup constitutes approximately in this 20 to 25% of the cases where there will be faint or incomplete membrane staining in equal to or less than 10% of the tumor cell. So here, it's a bit different. So this should be classified as ultra low, and pathologists do at majority of the centers now do this. So this has bifurcated IC 0 into 2 groups, ultra low and actually absolute negativity based on IHC. Now, in Destiny breast trial, TDXD study was studied in hormone receptor positive, HER2-neu low and ultra low both, who were chemotherapy naive MBC when compared to physician's choice of treatment. So how it is different from Destiny breast 4, that it has incorporated approximately 20 to 25% of HER2-neu ultra low category, which is potentially eligible for DDXT. And it has also moved the role of TDXT in the earlier line of treatment, because I will tell you the eligibility criteria of this trial and then you will understand it better. It has expanded the proportion of patients who may benefit from TDXT to approximately 85% in hormone receptor positive and HER2-neu negative MBC. Yeah. So, I'm not going to tell you how trastuzumab deruxtecan works. You already know this has got trastuzumab, a linker protein, and then topoisomerase 1 inhibitor. It has got a bystander effect because it can permeate the membrane and go outside and damage the adjacent cell. Now, coming to the Destiny breast 6 here, hormone receptor positive MBC, those who had HER2-neu low or ultra low were, studied in chemotherapy naive setting. Prior treatments, more than 2 lines of hormonal treatment plus minus targeted treatment for MBC like CDK4/6 inhibitor were allowed, or 1 line in MBC and progression within less than 6 months of starting of ET plus CDK4/6 inhibitor were allowed, or when the recurrence happened in less than or equal to 2 years of starting time of hormonal treatment. Into 1:1 randomization to TDXD or the physician's choice treatment could be couple of options like capecitabine, nab-paclitaxel or paclitaxel. Primary endpoint was PFS in HER2-neu low, but couple of key secondary endpoints like PFS in ITT, which included both HER2-neu low and ultra low, OS in low, and OS in ITT, which included HER2-neu low and ultra low. Now coming to the result, when you see the PFS, it was delta was 5.1 month, difference favoring TDXD compared to the physician's choice treatment. And this was statistically significant. And this median was 13.2 months here versus 8.1 month. TDXD demonstrated statistically significant and clinically meaningful improvement in PFS compared with standard of care chemotherapy in HER2-neu low subgroup. Now, OS was not greatly different because of the crossover allowed. And if you see 1/5 of the patient here in the TPC group received TDXD post-treatment discontinuation in HER2-neu low subgroup and approximately 18% in the ultra low subgroup, not ultra low, low plus ultra low subgroup, which is the ITT population. but numerically still it looked better, 87.6% versus 81.7% at 1 year in the HER2/neu low. And when you see both low and ultra low combined, 87% versus 81% at 12-month difference. Now, there were more and good number of patients who responded more, whether it was HER2/neu low or ultra low. So if you see, only 1/3 of the patient did respond to the chemotherapy in the physician choice arm versus, approximately 56% in HER2/neu low subgroup. And when we talk of HER2/neu ultra low, approximately response rates were 62% versus 26%. So that tells you that T-DXd has significantly higher response rates compared to chemotherapy, with over half responding versus 1/3 with the chemotherapy, and showed uniform efficacy across HER2/neu low or ultra low subgroup. So T-DXd based on this trial demonstrated a statistically significant and clinically meaningful PFS benefit versus physician's choice treatment in this hormone receptor positive and HER2/neu low MBC in the earlier line of treatment than DESTINY-Breast04. Results of HER2/neu ultra low were also consistent with HER2/neu low. ORR was higher, in T-DXd. No new safety signal were identified, and interstitial lung disease, we know that is an important safety risk for T-DXd and should be monitored properly and appropriately and identified earlier. So the DESTINY-06, what it did, it established T-DXd as an effective new treatment option for patients with hormone receptor positive, HER2/neu low and HER2/neu ultra low MBC following more than or equal to one endocrine treatment. Now, this is what, ESMO guideline also has, because of this newer trials, they have updated this. And if you see the NCCN guideline, they also say that this is for HER2/neu negative group, but those who are hormone receptor positive with visceral crisis or endocrine refractory. So, if there is no BRCA1, BRCA2 mutation, and if the HER2/neu is low or ultra low, they have incorporated FEM trastuzumab deruxtecan as a treatment option in first line setting 2. And if it is second line setting we are talking of, then this is category 1 and the preferred option because of the trial DESTINY-Breast03 that we discussed. And a third line can be, something else which is beyond, say, Cleopatra or beyond, say, T-DXd type of regimen. So key takeaway from whatever I have discussed is that in Breast03, T-DXd become the standard second line treatment, displacing T-DM1. And based on DESTINY-Breast04, effective treatment is now available for eligible patients classified as having HER2/neu low breast cancer. DESTINY-Breast06 established, T-DXd as an effective new treatment option for patients with hormone receptor positive, HER2/neu low or ultra low MBC. Guidelines recommend T-DXd for treating HER2/neu IC 0+, which is ultra low, 1+, or 2+ if FISH negative. So this is all. Thank you very much for kind and patient listening. If there are any questions, I can take them on, or if you want to discuss during panel discussion, it can be done that way too. Thank you very much.
Yes, sir. Thank you, sir, for those valuable insights. So now moving ahead, it is my pleasure to introduce Dr. Indu Arun, a senior consultant in the Department of Pathology at Tata Medical Center, Kolkata. Ma'am, over to you, please. So she'll be presenting on HER2 ultra low and emerging frontier in breast cancer treatment. Ma'am, over to you.
Thank you. First of all, I would like to thank the organizers for having me here. Are you able to see my presentation?
Yes, ma'am. Yes, it is visible, ma'am.
So I'll start with some basics on HER2 receptors and how the HER2 testing has evolved over time. So HER2, as you all know, is a proto-oncogene which is located on the long arm of chromosome number 17. And the normal breast epithelial cells have have 2 copies, HER2 gene copies, and about 40,000 HER2 receptors. When HER2 is positive or overexpressed, the number of protein receptors on the cell surface increases to about 100 or 200 folds, and you can see more than 2 lakh HER2 receptors on the cell surface. So the most common method which is used to assess HER2 protein overexpression or HER2 status in breast cancer is immunohistochemistry. And the staining intensity depends upon the number of HER2 protein molecules on the cell surface. So in the original trastuzumab trials, the IHC staining was scored semi-quantitatively according to the intensity and completeness of staining of the cell membrane. And these trials showed strong association between protein overexpression, high HER2 gene copy number, and showed clinical benefit from trastuzumab patients with HER2 positive breast cancer. All this have led to the development of PERCEPT test, which is the first US FDA approved companion diagnostic IHC kit for testing for treatment with trastuzumab. And all this test was developed to detect HER2 protein overexpression. So since the anti-HER2 therapy is entirely dependent upon the HER2 test results, it became important that guidelines to be put forward so that the reports are reliable and reproducible. And the first ASCO-CAP guideline was published in 2007, and this was followed by further refinement in the guidelines in 2013 and followed by 2018 and most recently in 2020. So the 2023 guidelines affirmed the 2018 guidelines, which is actually meant for defining or identifying HER2 positive or hormone or HER2 positive or HER2 overexpressing tumors, which target the HER2 signaling or oncogenic pathways. So as you know, there are these four categories, that is IHC 3+, which is positive, and 2+, which is equivocal, and scores 0 and 1+ are considered negative. The ASCO-CAP update in 2023 also acknowledged the two categories of low expressing, HER2 low expressing categories, that is HER2 low and ultra low. So HER2 low is defined as IHC 1+ and IHC 2+ FISH non-amplified, while the IHC 0 has two staining patterns, that is no membrane staining at all or HER2 null, and those with faint, barely perceptible membrane staining in less than or equal to 10% of tumor cells, and these tumors are designated as HER2 ultra low. So the importance of these low expressing, HER2 low expressing tumors, that is HER2 low and ultra low, is that these tumors are now eligible for treatment with antibody drug conjugate, that is PDXT, which Dr. Amit was talking about in this session. So there were two trials, the Destiny 06 and 04 trials, to determine the efficacy of PDXT in HER2 low tumors. While HER2 04 trial studied the HER2 low expressing tumors, in Destiny 06 trials, they examined both HER2 low and ultra low tumors. So when these tumors were, when the tumors which were reported as IHC score 0 were re-examined in Destiny 06 trial, it was found that about 20 to 25% of these tumors constitute HER2 ultra low. So because of these trials, the HER2 negative space has evolved to include HER2 low and ultra low as actionable categories. This raises a debate that whether the presence of any HER2 membrane protein even below the IHC detection thresholds, whether this may enable PDXT activity in a subset of tumor cells, express sufficient HER2 molecules for internalization of the cytotoxic drug. So there are two evolving guidelines, important guidelines regarding testing of HER2 low and ultra low, that is ESMO expert consensus statement and ASCO-CAP guidelines. Although the ESMO consensus statement, they agreed that the HER2 low may be used as in the clinical practice for cases determined as IHC 1+ or 2+-ish negative. The ASCO update, they suggested that there should not be any change in the original reporting and scoring terminology, and the pathologists should not use the word HER2 low in their report. This is because the terminology HER2 low was used in the trial as a shorthand for identifying IHC 1+ and 2+-ish non-amplified cases for trial eligibility. And since IHC 0 was not included in this trial, it was not sure it was not known, the efficacy of TDXT was not known in this group. And there is no evidence that HER2-low is a new or reproducibly defined subtype of breast cancer with definite prognostic or predictive implications. However, they suggested that IC0 and 1+ should be separately identified and the score should be reported, but the results should be still reported as negative. So this is following the Destiny 06 trial, TDXT got approval for treatment of HER2 ultra-low patients. Hence, the NCCN guideline used IHC 0+ as a terminology to identify patients with IHC 0 with membrane staining, that is HER2 ultra-low. So this terminology IHC 0+ was adopted in the updated CAP breast cancer biomarker template, which was released recently in 2025. They subclassified HER2 negative 0 group into score 0, that is absent membrane staining, and 0+ with membrane staining, that is which constitute the HER2 ultra-low category. And they suggested that the exact staining pattern for each score should be included in the report. And an optional reporting comment can be added in the report describing the definition of HER2 low and ultra-low categories and used in each of these trials. There are challenges in identifying the HER2 ultra-low breast cancer patients or breast cancer cases by the pathologist because and the studies have shown a lot of inter-observer variability in identifying HER2 ultra-low cases. This is because of the faint staining which is seen in HER2 ultra-low cases, which is seen only in 48 magnification, and there are individual differences in color perception. And there are confusion regarding the cytoplasmic and non-specific staining. This shows that there is the requirement of reliable HER2 testing methods to identify low levels of protein expression. This is one article which was recently published in Modern Pathology, and it's an international expert consensus recommendation for HER2 reporting with focus on HER2 low and ultra-low categories. And this was by M.R. Praka and et al. And this is a very good article which gives recommendations for accurate identification and reporting of HER2 low and ultra-low breast cancer. This requires identification of ultra-low breast cancer, requires stringent quality control measures and harmonized pathology reporting. And these recommendations can be discussed under pre-analytical, analytical, and post-analytical considerations. Among the pre-analytical considerations or the recommendations, it is the same as the previous ASCO-CAP guidelines, that is the fixation time, the tissue should be fixed in 10% neutral buffered formalin, with and the fixation time should be between 6 to 72 hours and up to a maximum of 96 hours. And the cold ischemia time should be as short as possible and should be within 1 hour. And this is because the delay in fixation, that is increase in cold ischemia time, can result in decrease in antigenicity and can cause false negative results. So HER2 ultra-low tumors, that is IHC score 0+, may appear as HER2 null or IHC score 0. Regarding the sections which are used for testing HER2 low and ultra-low, the section should be 4 micrometer and should be cut within 6 weeks of HER2 staining. Freshly cut sections are preferred because there is chance of decrease in the HER2 signal intensity and antigenicity over time. And the preferred tissue block is the most recent tissue block should be used for testing, preferably the biopsy from the metastatic site. The sections which are stored for more than 6 weeks should not be used for HER2 testing. And on-slide external control should also be ideally cut at the same time when the test is being sectioned, because in order to compare the optimal staining. So regarding which sample should be selected for testing HER2 low and ultra-low, is it the primary tumor or the metastatic, the biopsy from the metastatic site, which tumor should be selected for the testing? So the studies have shown that there is a lot of discordance between the HER2 low and ultra low results between samples, that is between core biopsy and excision, and also between primary tumor and metastatic site. And studies have this particular study where HER2 testing was done on matched primary breast cancer and residual carcinoma and primary breast cancer and relapse. It showed that there is a switching of HER2 0 to HER2 low in about 10 to 15% of cases. In Destiny 04 and 06 trials, when a subset analysis was done, progression-free survival benefit with TDXT was consistent across subgroups, including IHC score, sample type, irrespective of whether it was biopsy or excision specimen, and tumor location, that is either primary or metastatic site versus physician's choice therapy. So the recommendation. Sorry, I can't move the slide. Yeah. So the current guidance is that if any tumor sample during a clinical course is scored as HER2 low, the patient is eligible for consideration for TDXT therapy. And I already mentioned the ideal the sample is the FFP blocks of the biopsy from a metastatic site. While FNA and decalcified bone metastatic specimens are not reliable, this is because if the testing is done on a cell block, there is chance of background staining, and there is a difficulty in interpretation. And in decalcified tissue may show decrease in antigenicity, and it is not reliable. It is not recommended to repeat the testing on file blocks. This is because old blocks, and it can be done only if the original specimen was reported as HER2 0 and it is not distinguished as HER2 null or ultra low, and if it is found that TDXT is beneficial in this patient. In such cases, test the most recently stained slide, and the block should be preferably less than 5 years old, with a caveat that the reactivity may fade over time. If uncertainty persists, test additional blocks from the same or alternative sites. So regarding the analytical considerations, in the DB06 trial, they retested all the samples using the FDA-approved Vendana 4B5 assay with the ultra-view detection system to ensure consistency. There are several CE IVD-approved IHC kits and standalone laboratory-developed tests available. These assays use distinct antibodies which have different sensitivity and specificity, and these antibodies are developed or optimized for testing HER2 positive breast cancer only. And the current evidence indicate that specific FDA-approved companion diagnostic assay reproduces the diagnostic and therapeutic outcomes reported in DB04 trials. And hence I can't move this out. So that regarding the recommendations for assay selection, validated guideline endorsed FDA-approved assays are preferred, and currently Vendana HER2 4B5 assay with ultraview log protocol is advised. And alternative validated HER2 assays can be used, but the results should be cross-validated with Vendana 4B5 assay platform results. It is very important to use quality control measures and to use validated HER2 controls, and if possible, include internal control, and always include an on-slide external control with full range of expression, that is 0, 1+, 2+, and 3+. Either cell lines or tissue samples can be used, and it is important to participate in external quality assurance programs and conduct internal audits and reviews, that is re-evaluation of previously reported slides can be done. Regarding the post-analytic considerations, regarding the HER2 immunohistochemistry interpretation and scoring, HER2 scoring should be done by trained pathologists, and dual reporting can be done. That is, you can ask the help of another pathologist in difficult cases. And to distinguish, so as you all know, the distinguishing IC0 from 0 plus is very difficult, and you can use the magnification tool. That is, HER2 IC3 plus is easily recognized in the scanner objective, that is 2.5 to 5x objectives. 2 plus is identified, that is 2 plus staining shows moderate to weak intensity staining. So moderate intensity staining can be seen at 10x and weak intensity at 20x. And 1 plus staining is weak or faint, which can be seen either in 20x or in 40x. 0 plus staining is seen only in 40x objective. So how to report? It is advised so the report should have clinically relevant information. So it is advised to use synoptic reporting, such as CAP protocol can be used. This I've already discussed. So the updated CAP biomarker reporting template has also included the different staining patterns, the Anushan staining patterns, which has to be categorized under equivocal score 2 plus. This is this flow chart. This is a beautiful flow chart which is given in the modern pathology article, which I referred to previously. And this flow chart shows the various combination of intensity and completeness of staining and the percentage of tumor cells showing the expression and the corresponding score. And this will be very useful while reporting. So the role of AI, as this previous speaker mentioned, the AI tools can enhance the accuracy and reproducibility of HER2-low and ultra-low scoring, but current evidence show that there is a lot of variability in performance across different AI platforms. And at present, if AI is used, it should be used as an adjunct and not a replacement for expert pathological assessment. So the key takeaways are the accurate reporting of HER2-low and ultra-low breast cancer is vital, as these patients can be targeted with TBHD. However, exact reporting of HER2 or distinguishing HER2-low and ultra-low can be challenging for pathologists due to its heterogeneity and because we have to assess the lower levels of expression of HER2. And accurate assessment requires adherence to updated HER2 guidelines along with robust quality assurance practices. And it is important to standardize analytical detection of HER2 at very low levels. And further research is needed to develop more quantitative methods to detect HER2, to identify the lowest cutoff, that is any level beyond which the activity of PhD is limited. Thank you.
Thank you, ma'am. So, does anyone have any queries or require further clarification at this point? So, okay. And I request the participant to please post your questions in the chat box and they will be addressed at the end of the session. So, we now move to the most interactive segment of the evening, the panel discussion. I'm pleased to invite our moderator, Dr. Demalya Banerjee, a consultant and lead oncopathologist, Narayana Health, Kolkata, to take charge of the discussion. Joining him as the panelist are Dr. Rakesh, an associate consultant in molecular pathology and laboratory hematology at Tata Medical Center, Kolkata. Dr. Jehati Datta, a consultant histopathologist and at Dr. Tribedi and Roy Diagnostic Laboratory, Kolkata. Dr. Arpan Ray, consultant pathologist, ESI Hospital, Manikatla. Dr. Rajiv Bhattacharjee, a consultant medical oncologist at Peerless Hospital and B.K. Rai Research Center, Kolkata. Dr. Dhitiman Maitra, a associate professor, medical college and hospital, Kolkata. Dr. Debajan Ghosh, a consultant histopathologist and cytopathologist at Chittaranjan National Cancer Institute, Kolkata. So, ladies and gentlemen, with this faculty panel, I hand over the session to Dr. Demalya to begin the discussion on HER2-low and ultra-low when negative no longer means nothing. Sir, over to you, please.
Thank you, madam.
Thank you.
So I'm very thankful to the IAIO and AstraZeneca for giving me the opportunity for discussing these interesting panel discussions. Before that, there's a excellent elaborative discussions by Indu madams on all the pathology aspect of the heart to new low and ultra low, and before that by Dr. Amit sir, the clinical values of the what is the low and ultra low reportings and how the patient will be benefited. Most welcome to all my panelists here. Before starting today's discussions, in very short, if I say the two words for the Destiny Breast 4 and Breast 6 trials, which make these changes. So, Breast 4 trial establishes that HER2 low, that means IHC 1 plus, IHC 2 plus with in situ hybridization negative metastatic breast cancer as a new targetable patient population with TDXD.
Dr. Devmalya,
Yes.
sorry to interrupt. The screen is not visible, sir.
Will you please share the screen? I cannot share it. Please share the screen. Do you have the PPT? So please share it.
Yes, sir. Sure, sir.
Yeah, thank you. So next slide. Next slide, please. So Destiny 4 breast 4 trial that shows that. Please change the slide. Okay. Yeah. And similar to the Destiny 6 trial, if we see that the breast 6 trial establishes that TDXD as in the effective new treatment option for the patients with the hormone receptor positive, HER2 low and HER2 ultra low metastatic breast cancer following the more than one endocrine based therapy. So these are the take home message from the Destiny 4 and Destiny 6 trial. And our today's discussions, most of the discussions is based on these two trials. That's why I just discuss this in a very nutshell. Next slide, please. So my first question to the medical oncologist, Dr. Rajiv, is that Destiny 4 and Destiny 6 trials showed that benefit even in the HER2 low and ultra low patients. So these ultra low patients were the previously were declared as a negative, as a binary type of the reporting pattern of the HER2, either positive or negative. And a big part of the HER2 low patient also were considered as a negative. Now, this new changes how influenced your perception of the HER2 negative. And obviously, not only the your perceptions, how it influences your treatment decisions. So if you discuss with that in a very short manner. Rajiv is available here.
Sir, you'll join.
Okay. So, okay. So my next question to molecular pathologist, Dr. Rakesh. We know that is a HER2 is Dr. Rakesh is available.
Yeah, I'm here. Please.
Okay. So that there is a heterogeneity in the HER2, and there is a heterogeneity is in both the temporal as well as the spatial heterogeneity. So within this and spatial heterogeneity means it is the positive in different area, it is the low in different area, it is the negative in different area, the same tumor at the same time. So as a molecular standpoint, how significant is the spatial heterogeneity of the HER2 expression within the same tumor? And as a in the India, as a resource constrained country, the single block testings risk is a riskful, so you can miss the targetable patients. What is your suggestions, your input in this context?
So spatial heterogeneity is commonly seen in HER2 expression. Between in the same block also you can see intratumoral also. And if you have metastatic setting, in that also if you have mets to liver, then the expression is totally different. So if you have intratumoral heterogeneity, IHC might be not a good tool when you can miss, like if you go with a traditional tool like IHC 1, 2, so you have 10% cutoff. So if you have heterogeneity or where the expression is too low, which cannot be picked by the IHC, In that case, the patient might not get the benefit of HER2 targeted therapy, and it is very commonly seen. So to act on it, I think there are a lot of new molecular tests which are coming up, which target the mRNA expression of HER2. So there can be no amplification on the tumor cell, but the expression level can be high. That can also be seen in case of HER2 when you target the expression level of ERBB2. And single block testing is still carried out at many places, but with the adoption of this molecular test, like for example, if I give a simple test by digital PCR, you can quantify, or by real-time PCR also you can quantify the expression level, which can be missed on IHC or which is negative on IHC.
That is very fantastic thought. But is there any standardized protocol of the ddPCR quantification of the mRNA levels with the HER2 expressions? Any
Yeah.
guidelines or any standardized protocols are available in our country? Not only our country,
Yeah.
also in also
So
outside also.
CAP gives some guidelines, but still it is very at a basic level where it
Yeah.
is not mature. And in India, it is still has to be adopted at a mass scale. But the centers like us, where we have digital PCR, we will definitely look to start with the mRNA expression quantification to give the benefit to the patient.
Okay. So it is possible, according to the part of discussion with Dr. Rakesh, that is it possible that a ERBB2 gene is amplified but is not expressed in the antigen level. So that patient we can be missed if we solely depends on the IHC expressions as a evaluation tools. So my next question to the surgical oncologist, Dr. Dhitiman, is that the HER2 or low and ultra low status really influences the neoadjuvant treatment choice and consequently surgical planning or the extent of surgery. Um, as for medical oncologists, definitely they make a big changes, but for the surgical oncologists, so is it really make
Sir,
some changes?
sir, sorry to interrupt. Dr. Rajab has joined, sir.
Oh, thank you.
Thank you.
Dr. Dhitiman is there?
Yes. So, thank you, Demalo, for this question. Uh, what you want to know is whether, as of now, in HER2 low and ultra low, neoadjuvant treatment or surgical planning would be affected or not. As of now, I think we are in a nascent phase with respect to trastuzumab deruxtecan in neoadjuvant setting. So as of now, only for HER2 3 plus cases, we are considering neoadjuvant chemotherapy with our conventional trastuzumab. And for tumors which are 2 centimeter or more, or for node net positive cases.
Exactly.
But for smaller tumors, node negative cases, and HER2 2 plus fish negative and HER2 1 plus and 0, we are not considering cases for neoadjuvant chemotherapy, if unless they are in locally advanced breast cancers, but not in early breast cancer. And regarding the extent of surgery, I don't think the tumor biology affects the extent of surgery. We offer breast conservation surgery even to patients of triple negative variety. And also, if patients are BRCA positive, we keep it open to discussion and whatever the patients opt for. Some patients, of course, opt for prophylactic mastectomy on the unaffected side also. The extent of surgery really depends on the patient's choice and a cafeteria kind of choice we offer to the patient. Uh, However, biology of the tumor doesn't generally preclude breast conservation. Breast conservation is contraindicated when there's a multicentric disease, irrespective of the patient's biological nature of the tumor. So that's how it is as of now. Um,
Thank you. Thank you, Dhitiman.
but
So as
just as
Mhm.
trastuzumab, then pertuzumab, then
Mhm.
in triple negative breast cancer, immunotherapy has now become a norm for I mean, locally advanced tumors as well as early breast cancer, which are node positive and 2 centimeter tumors or more. I think there's a possibility that in future trastuzumab deruxtecan will definitely, have a
The neoadjuvant.
role in neoadjuvant setting as well. Yes.
Okay, thank you. Rajiv, most welcome in the today's discussions. So, I just telling you the previous questions I asked for as a medical oncologist. So that is in the Destiny, before the Destiny based 4 and based 6 trial, it is a binary pattern of reporting of the R2. Rajiv is available now?
Yes, yes, yes. Can you
Yeah.
hear me?
Yeah, I can hear you. So before the Destiny 4 and Destiny 6 based trial, basically there is a binary pattern of reporting. So it's either positive or either negative. So now
Yeah.
it is not a typical black and white concept. It is a gray zone in between the black and white. So these
Yes.
HER2 low and ultra low, how these influenced your perception of the HER2 negative in current scenario, and obviously how it influences your treatment decision also. In a very nutshell, if you discuss with us.
Right. So actually, I have a nice story to tell because when I was preparing for my super specialization examination, that's the time when the Destiny Breast 01 came into vogue, and that was the first time we came with the drug that TDHC, trastuzumab deruxtecan, was a brilliant response. And while studying, we realized that there is a bystander effect where the linker of that ADC actually, the trastuzumab and the chemotherapy part, that breaks sometimes outside the tumor, into the tumor microenvironment, outside the
Yeah.
tumor cell, and thereby killing some of the cells in the tumor microenvironment which are not expressing HER2 at all. So that's where I think from where this concept of HER2 low or eventually ultra low came into being, that even a little bit of signal of HER2 might attract these drugs to the tumor microenvironment and kill those cells. So from then itself, from the first time I realized that when I came to university and I started practice, I had already started using the nomenclature of HER2 low. So at that point of time, not ultra low was there, so I was giving IC1 and IC2 fish negative as ultra low, and IC0 as negative. Now we have a separate nomenclature that now even the negative has become ultra low or null. So right now I
Yeah.
am, and I'm very fortunate that our the pathology department in our institute is also has gone on with the times, and they have given started giving report of HER2 null and HER2 ultra low as well.
Okay. Okay. Thank you. Thank you, Rajiv. Can you please change the slides? Next slide, please. Yeah. So this is a very interesting slides that we describe is basically for the pathologist, but all my clinical colleagues also I have some idea from these slides. So the most right one is the IC positive 3 plus. Basically, in IC interpretation of HER2, we see the three parameters. One is the percentage of the tumor cell, either 10 more than 10% or less than 10%. What exact percentage? Next is the intensity of the staining. That is, it is a strong, it is the moderate, or it is a weak. And number third, that is one of the important thing. It is the complete or incomplete. So if all three is one side, that is it is the more than 10% invasive carcinoma cells that are the strongly positive and complete membranous staining. Obviously, it is the 3 plus. And if there is an absence of the no complete absence of the staining, no staining is there, then obviously it is the null type. And in between there is the either low, ultra low, and these groups. So if the staining is a 2 plus ISC staining means it is the complete staining, but it's a moderate intensity and involving the more than 10% tumor cells. Definitely, this group of patients require the reflex fish testing. So if the fish is positive, then they are in the HER2 positive groups. If the fish is negative, then they are in the previously they are considered as the HER2 negative. But now this group is considered as the HER2 low group. Similarly, the 1 plus staining group, that means the tumor cells which show the incomplete, uh, faint, barely perceptible membranous staining in more than 10% tumor cells, they are also considered the IHC 1 plus staining. So this 1 plus and 2 plus fish negative is the HER2 low group, and in between the HER2 null and 1 plus, this area, that means the tumor cell which shows the very faint, barely perceptible but membranous staining, and obviously incomplete staining in less than 10% tumor cells, less than equal to 10% tumor cells, they are considered the HER2 ultra low. The interesting thing is that this low and ultra low group actually actually is that the 65% of the breast cancer patients. So this 60 to 65% breast cancer patients have the no targetable options there in the past, but currently we have the targetable options for them as the antibody drug conjugates. So my next questions to the Jayati, Dr. Jayati, is that with the 2023 ASCO cap and cap 2025 upgrades introduced at the HER2 0 plus ultra low category, how has the definition of the HER2 negative evolved in the pathology practice? So, and what practical challenges is there you faces every day in reporting the this HER2 ultra low group basically?
So earlier, our concept of HER2 was very binary,
Yeah.
and the reporting used to take seconds. If it is 3 plus, you can diagnose it in scanner. If it is negative, you can diagnose it in scanner, and somewhere in between, we used to dump it into 2 plus and then rely on FISH. Now this entire 0 or negative HER2 has been divided into null 0, where there is nothing, absolutely no stain, to 0 plus and 1 plus. So the behavioral change, I'd say, that the pathologist would require now is to examine the HER2 slides in 20x and 40x so that no staining is missed. And the practical challenge is that in this attempt, we also have to account for that we don't overcall the cytoplasmic blush as staining, or those particularly in micropapillary breast carcinoma, there is a fuzzy basal staining that sometimes come. So, and then in core biopsies, there is sometimes age artifacts. So all those we have to be aware that in an attempt to include, to find out, fish out this 0 plus and 1 plus cases, we shouldn't overcall. But I think the challenge of missing out is more, because traditionally we are not trained to spend so much time to interpret HER2 and give so much importance to HER2 IHC. So this shift of perceiving HER2 as a oncogenic driver mutation to HER2 as an actionable target, this shift of focus has to be imbibed by the pathologist.
So excellent discussion. So that the currently what is the problem is that the chance of the false negative is high, not the false positive. What Joytidi has explained just nicely, and it is currently the pathologist has a much more responsibility. We have to spend the much more time on the slides, scan the entire area, so that any area can shows any percentage of the tumor cells if shows that faint, barely perceptible, and these adjectives we have to really keep in our mind. It's not that not only that is written. So the faint, barely perceptible staining, obviously the membranous staining, we have to consider because the HER2 null and HER2 ultra low definitely has a big difference in their treatment managements. Thank you, Jyoti. So next, I ask Dr. Devanjan and Dr. Devanjan from the CNCI that the differentiating the 0 and 1 plus is very much meticulous and very much challenging, and its clinical is very much relevant for the therapy decision. So, what are the most common sorts of errors or disagreements among the pathologists, and how can they be minimized? If you say a few words on this, and with the same question, I also ask you the another component. So really, the AI will changes some difference, improve the interpretation of the ultra low and ultra low. What do you think? What is your experience or expectations?
Thank you, Devmaloda, for asking this question. The first question you have asked that interpreting the differentiate between the 0 and 1 plus. Whether I know that this is the thing, this is the area which is the most challenging for a pathologist. And for that, we have to report the ISC according to the ASCO cap guidelines. And we have to be sure that we have to see the slide in 40x magnification, the higher magnification, with the And if there is provision, we should check with the second pathologist and for their opinion. And we have to check the control slide also. We have to use the control slide for this. For differentiating between, particularly if we use 1 plus ISC slide as a control, that is very beneficial for us for correctly recognizing the 1 plus category. For different category 1 plus 0, we have to use the different controls. And we have to always check the pre-analytical error also before examining any negative cases, HER2 negative cases, for the optimum processing, tissue processing, optimum fixation time, and all those pre-analytical consideration. And for this, we should give much more time actually. We have to see the slides with much more concentration, much more time, not like Joyati has said that previously, just 3 plus positive and 0 is negative, not like that. It is now we have to concentrate more. For pathologists, it is a huge job to give a low and ultra low. And your second question regarding the AI based techniques, I think AI should definitely play a role in future, but AI cannot replace the role of histopathologist. AI will work as a additional helping hands for the pathologist to report these critical cases.
Thank you, Devanjan. So before going to the next point of discussions, I just want to tell, because as it is a very challenging for the pathologist and for reporting the HER2 low and ultra low nowadays, definitely AI will be helpful for us. It's a questionable. So Doctor, I just want to say one thing to Doctor, the molecular pathologist here, the Dr. Rakesh, that the mRNA is really be helpful for the mRNA evaluations by the ddPCR will really be helpful for the HER2, because see, the HER2 we have to see in the invasive carcinoma component, not in the DCIS. So that all the discussions is on the DCIS components. What is the DCIS invasive carcinoma component, not the DCIS? So the 10% or less than 10%, all are the invasive carcinoma. So does the mRNA expressions on the, is it possible to differentiate from the DCIS or from the invasive carcinoma? So I think the role of the IHC will never be decreased, and maybe in some cases where the IHC have some limitations, in that cases you can use as the mRNA expression pattern. But solely based on the mRNA expressions, can you differentiate between the DCIS or
So
invasive component?
apart from digital PCR, there is one more concept which is coming up, which is called spatial transcriptomics. So on a slide only, you can see the mRNA expression. So you can differentiate. The tumor will have a different color because based on the color, whatever fluorescent tag they are using for the transcriptomics. So that is also under research at many places. So spatial
Okay.
transcriptomics will have a reader also. So that reader will give some score. So whatever digital PCR also, if you have the mRNA, still the cutoff, like if you see the hematological malignancies where BCR-ABL have a cutoff, like below these copies it is negative. Still many things has to be developed for in cases of mRNA expression quantification. So the guidelines will develop once we get the data, and they will definitely have some cutoff. Beyond that, some action has to be taken. Like in IHC also you have 1 plus, 2 plus, 3 plus. So such thing will come into picture, and spatial transcriptomics will also come into picture.
Okay,
Where
hope for the best, hope for the future. Let's see. Next thing I just want to discuss is that the HER2 expression is very much dynamic. We have already seen that patients who are the initial the HER2 positives or HER2 negatives, they can be positive or can be negative when the tumor recurs, when it metastasizes in future, or when there's a distant metastasis there. So my first questions to Rajiv is that suppose a patient came to you with the old HER2 blocks. Patient has the 2 years ago, patient has the breast cancer, IHC for ERP HER2 was done, and he came with the HER2 report, old HER2 report, that is a binary pattern of reports and the old HER2 blocks. Now, what should be your practice? You should believe the historical HER2 score, or you do a fresh biopsy and the retest, or you do the retest and the rescore, or you ask the patients to submit the block to the departments and for the rescoring. So what should be the appropriate practice?
So for me, what I do is that because we have too much frequent, drugs, so what we do
I
is,
think there's a
oh, can you hear me? Can you
hack.
hear me right now? So what I will very cut short. If the previous biopsy shows a HER2 negative, then I do a rebiopsy. If the previous biopsy shows
Okay.
HER2 positive, in that case I go by that because we have targeted agent with that. You can call me biased, but that's how it is.
Okay. Okay, so the previous biopsy, if there was the HER2 negative, then you go for the re-biopsy. So,
Yes.
is it? Do you not believe that the re-evaluation of the same block can change the, because the old biopsy report is based on the binary pattern of reporting. So there's a 40% changes in the HER2 evaluations if you re-evaluate the blocks. So why you go for the directly go for the retesting before not evaluating the previous blocks? So it may be the R2 1 plus or maybe the R2 ultra low. So that is also considered negative in the historical times. That's my question.
Yeah, so definitely we can do that. So if we have a archival tissue which has quality tumor cells left in that, we can definitely go ahead with a repeat IHC and if required fish. But my point was if it was an old block, they have lost it, and it was HER2 positive, HER2 negative. Even in that case, I might want to redo a biopsy and check for HER2
Okay,
because if
okay,
it's now or even low or ultra low, I have a very good drug in my hand.
okay, okay. So next question to the Dhitiman is that because the tissue amount of the tissue is a very big issue. Why? Because there's a heart is a very much heterogeneous. It is for the breast cancer as well as the gastric cancer also. So, do you believe the core needle biopsy is sufficient to reliably assess the HER2 low or ultra low status, or should the excision specimen be preferred whenever feasible to just to deal with the intertumoral heterogeneity? So, what is your call in this aspect?
Demalo, there are two aspects to it. See, like when we are taking the core biopsies, we are taking core tissue and immediately we are putting them into formalin
Yeah,
and we are sending it for testing. So, tissue preservation is better with cores. And when you're operating, you start to operate parts of the tissue, the tumor tissue starts to lose its blood supply. And by the time after 1.5, 2 hours, or say, even if you're a very fast surgeon, 30 to 45 minutes when you are done with the procedure, and it is a huge, if it is a mastectomy specimen, it's large, only a part of it has the tumor. And if even if it is a breast conservation surgery specimen, it is much bigger than a core biopsy specimen. So the penetration of formalin, tissue fixity, those things become more difficult with a whole
specimen.
specimen. However, the whole specimen takes care of the head tumor heterogeneity aspect. But even with core, how we can overcome this tumor heterogeneity issue is that by taking multiple cores from different
Yeah,
quadrants of the tumor. So I think the current standard is to take around 5 to 6 cores from different parts of the tumor so
absolutely,
that
absolutely,
there's a representation of every part of the tumor and it takes care of the heterogeneity to some extent. I think that that
exactly,
is the current practice.
exactly.
However, with for patients who are designated as HER2 1 plus or HER2 0 plus or HER2 null on core biopsy, there is still room for repeating IHC for HER2 on the final specimen also. So, we have to wait for the
Exactly,
future
exactly.
recommendations or guidelines. But as of now, we are not repeating on all patients.
Okay, okay, thank you. Next slide, please. And there is a first time someone, a surgeon has told us about the warm ischemia. That is excellent because every time we discuss about the cold ischemia, it is a lab responsibility. So not only the cold ischemia, the warm ischemia. So after the ligation of the arteries and removing the specimen also influences your HER2 expression, the warm ischemia time also.
Yes. So
That
that
also
is
to keep
this
in mind.
problem does not exist with core biopsy.
Yeah.
But this problem exists with surgery. So that we have to admit.
Thank you. Thank you. Okay. So next slide, please. Please change the next slide. Next slide. Yeah. So prevalence of the HER2 ultra low among the patients with the advanced breast cancer with historical IC 0 status, and that percentage is very much shocking. It is almost a 43 to 45%. So my next questions to the Joyatidi is that given that the 40% of historical HER2 zero cases can be reclassified as the ultra low, should rebiopsy and rescoring be encouraged for the patient's progression on therapy? What is your call?
Yes, absolutely. Rebiopsy and rescoring is the way to go because uh, before this antibody drug conjugate came in the market, the pathologists were not aware of significance of HER2. So I don't think the HER2 would have been given that much importance the way it is given now. So it should be rechecked. The patient can get a lot of benefit from that.
Thank you. So, Orpon,
Demal, can I add a point to this?
yeah, please, please, please.
When there is a recurrence in a patient who was HER2 negative on a report, on a, on
Previous
a
report.
biopsy which was reported, say, 5 years back, it is, it is always good to look at the previous report to review the report and see whether it was low or
Yeah,
ultra
it is
low
a
or
null
which
or it is a
variety
low or
of.
ultra low.
But when there is a recurrence, some tumors also change their,
Yes.
Biology.
molecular
Profile.
Yeah,
subtype.
that is very well
So,
known.
it is I think it will be a good practice to review the old reports for a fresh HER2 status, as well as rebiopsy and re-examine
Exactly.
the current tumor's biology.
Exactly. Exactly.
Yes, thank you.
So thank you. So the next question I asked to the Dr. Orpon. Orpon is in the ESI hospital, ESI Maniktala. So
Yes,
how
sir.
does
Good
the
evening.
pre-analytical factors, suppose your fixation time, your tissue handling, your decalcification, the bone meds, so influences the accurate HER2 scoring. So pre-analytical factor is a big challenge for us. So if you tell us few words on it.
Yes, sir. First of all, good evening, sir, and thank you very much for giving me chances for this beautiful webinar. I hope my words are audible,
Yeah,
right,
you're
sir?
audible. You're audible.
This pre-analytic, as before, as my the previous the teachers and professors, they say that Indu madam also said this is very important in a case. This pre-analytic IC refers to all steps before the actual staining process, from the tissue collection, like the factors warm ischemia, to the fixation, like type delay to fixation, and the time in fixative, and the processing embedding, which is very much important here, because sir, this ER-peer and HER2 and all these things, specifically HER2, this is very much depending upon the tissue fixation. The type, that is the 10% neutral buffer formalin, and the duration of the fixation are critical. Insufficient fixation or delayed fixation, like over 16 to 24 hours for biopsies, that will damage the epitopes and it will leading to false negative. And the tissue processing, which is very much inconsistent processing, like the temperature, the buffer pH, and embedding, it will also alter the protein structure. So it's very important, sir, the tissue handling also, like delays between the biopsy and the fixation, or improper handling, like in core biopsies, that will definitely affect the results. The antibody, it will definitely affect the results. Now, the most important point here, that the both the HER2, the concordance, that is poor handling, can lead to the false negative results, like misclassifying the tumors, like it will be HER2 negative in many cases I have seen also. So the tissue fixation, the type, the formalin is important. The insufficient fixation can lead to protein degradation, second point, and prolonged fixation will mask the epitopes, will affect the antibody binding. And sir, about the time is very important. The time between the tissue removal and fixation, like if it is more than 1 hour for breast tissue, it will impact the
Or less
receptor
ischemia.
stability.
Okay.
It will impact receptor stability, and sir, and the tissue processing, like the temperature, the buffer, the paraffin embedding conditions, it will influence the antigen retrieval and staining quality. So, sir,
Thank
the important thing which I think, sir, that as a pathologist, we should always think the pre-analytical thing. It is very important. If the pre-analytical error is there, then it will definitely affect the HER2 and the HER2, and I mean the HER2 IC. It will definitely affect the results. It will definitely mask it. It is that, sir.
Thank you. Thank you. Thank you, Arpon. So next
Sir, sir.
things are also very interesting and very important for the pathologist. That is what is the antibody clone you're using. So we'll ask Dr. Devanjan that the Destiny Breast 4 and 6 trial, they use a very specific clone, a 4B5 antibody. So next slide, please. Yeah, 4B5 antibody. Now to detect the HER2 low and ultra low breast cancer. However, in the India, here is a resource constrained country and the multiple labs uses the different antibody clones. Some labs also uses the manual staining also. They don't have the automated IC platform also. So these influences the HER2 results. Really, will that impact the identification of eligible patients with the intent to treat with the TDXD? So that clones or the different IHC platform or the manual staining does have some influences on the evaluation of the HER2, specifically for the low and ultra low. What is your opinion on it?
Thank you, Devmaloda, for the question. What I feeling that FDA approval is for the Ventana pathway, that 4B5 monoclonal antibody to run this and report this HER2 for low and ultra low cases. But how many institutes have that? I doubt. This Ventana pathway and lots of, as you said rightly, that lots of other lab also, they are performing this ISC in other instruments and other reagents and other.
And some in the manual staining also.
Manual staining also, some of them. But what I feel that we should see this in any of the whatever we are performing. We should see this the staining pattern, not necessarily that we have to run in Ventana, but whatever we have, whatever the instrument reagent for the manual staining, we should report that HER2 negative cases, particularly these 0 and 1 plus, low and ultra low, and we should mention the clone and antibody what we are using in our report, and we should also validate that our test. The validation is very, very important. We should properly validate our result, and also also with the control we are using for each and every cases. That is very, very important for reporting this HER2. And for each and every score, as for that guidelines, that ASCON CAP guidelines, they clearly mention that for reporting this 0 and 1 plus, we should use the control for this 0 and 1 plus separately. So if for any method we are using for ISC, whether manual staining or any other platform, I think these factors is very, very important. We should mention in our report what the antibody we are using, what platform we are running the ISC, and what are the validation is there, what is this clone we are using, and what is the performance of the control. So I think this we should report, we should mention in our report.
So everything should be very much clear in the report so that
Yes.
the medical oncologist, surgical oncologist, they also have some idea what is going on.
Yes, yes.
Thank you. So my next question to the Dr. Rakesh as a molecular pathologist is that suppose a patient has a IHC is a 0, R2 reporting as a 0, it is a null type expressions, not the historical 0, it is a null type expression, but in a mRNA expression profile, you have seen that there is a mRNA expression profile is there. There's expressive mRNA. So this kind of discordance, how you communicate to the medical oncologist in your hospitals if the situation arises, and why this is important, because we do not want the under treatment as well as over treatment also, because the TDX or ADCs are all very much costly medicines still now. So how these communications it performs in your institutions just to make the optimum treatment?
So when we see the recent CAP guideline, so now we have many more categories. We have low, ultra low, and null. So when we compare to the traditional where it was reported as 0, so that will be now classified as ultra low. So we can communicate to the clinician, or we can write in the report somewhere ki IHC 0 doesn't mean that the IHC expression, it can be categorized as ultra low. And then there is no, as far as I know, any guideline where the treatment can be given for ultra low currently. But in the report, if clinicians want to act on that, they can definitely act, considering that it is ultra low, and they can go for mRNA expression if it is available.
Okay. So Rajiv, any idea of your any guidelines or any your own practice that depending on the mRNA expression pattern. So suppose if it is the IHC is showing is that the IHC is the null type of expressions, but your mRNA expression profile also is report show that there is an expressive mRNA. So what do? You will go for the treatment with the ADC, or you just consider it as a hard to negative?
Well, currently there are not much evidence going by the gene expression with the ADC, but there are some studies which have used anti-HER2 agents in these group of patients who are HER2 low, but who have we have ERBB2 expression. In those situations, I think we can go ahead with at least anti-HER2 directed therapy, if not ADC. ADC does not have evidence, but we know there are evidence of trastuzumab, we have evidence of tucatinib, and definitely I think TDXD may come with some evidence in recent future as well. So
So
it
till
is
there
definitely.
is no standard guidelines to
Okay.
act. So
Correct. But the
mRNA
data is generating.
level.
So definitely in future we will get the
Yes,
clear-cut evidence-based guidelines that
correct.
depending on the mRNA expression profile, how we'll
Yes.
manage the patients. Thank you very much.
Many centers are not doing mRNA expression now. So it is still very early
Okay.
stage
Okay.
for
Okay.
physicians also to act.
Okay. 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 Thank you. Acha, my next question is to Jayatri, because she is working in a referral laboratory. So you are also getting the breast biopsy blocks basically for the second opinions, re-evaluations, who are already tested at the periphery, and you are getting the IHC in your centers when you are doing. There is a concordance. Suppose outside they are reported as a negative, and you are getting the 1+ result. As outside they are reporting as a 1+, you are getting the 2+ result. So in this kind of concordance, do you handle this concordance between the local lab and R2 reports and the central your referral lab retesting? How you communicate with the patients or the clinicians?
So, whenever there is a discordance from the original lab, and it is common, it is pretty common
Yeah,
because of the reasons you mentioned earlier. Many labs are doing IHC testing manually. Maybe the incubation time was not proper. Maybe the antigen retrieval was not done properly. So there are many pre-analytical, analytical steps where discordance may arise. To communicate that, we take cognizance of that in our report, that the prior report, I word it like this: the prior report of HER2 negative or 0 has been noted, and the test has been is usually reported or signed by two senior
pathologist.
pathologists, so that there's no room for subjectivity.
Exactly.
And oftentimes, this discrepancy is also because the choice of block in excision specimen has been different. Like
Yeah.
the outside place has chosen a block where the necrosis was more, where the
Rushing, suppose.
yeah. So we demand, if it is very common practice to send single block from a mastectomy or wide local excision for ERPR HER2. It is our lab practice to ask for all the blocks available of the surgical specimen. We even if there's no opinion asked for, we cut all the available tumor sections, and we choose our block wisely. So we mentioned that in our report that our testing has been done in so-and-so block, which is different from the original lab, and our test has been reviewed by two pathologists.
Excellent. So this is all the measures that can be taken to negate the subjectivity in the hard to ultra low identifications, and for the optimum reporting. Next slide, please.
I have one question to Dr. Jayati. So in the case like you have told ki you ask for multiple blocks and you cut the section. So in such cases, tissue microarray will play a role to ease your work, because in a tissue microarray you can see multiple section in a single slide.
Yes, but the amount of tumor is too low.
Yeah.
The area would be too low.
Okay.
The most important use of tissue microarray in the discussion of HER2 is used as control. This point also I wanted to highlight. Many of the labs are only using HER2 3+
3+ control.
as on-slide control, and you would never know you are missing out on 1+ and 0+ cases if you don't use a low positive control on your slide on every case. So that's the way to go.
Exactly.
Okay.
Next slide, please. Next slide. Next slide. Next slide. This all we have already discussed. Next slide. Next slide. Yeah. So, as a medical oncologist, I'll ask Dr. Rajiv, how do you adjust the treatment planning when you know the HER2 expression is heterogeneous within a patient's tumor? So you give a report where pathologies are mentioned. There is a heterogeneous pattern of the HER2 expressions. Some area shows that the 2+ staining, some area shows the suppose 3+ staining. So how many number of the in that case situations do you ask for the test the in separate blocks of the HER2, or you start treatment depending on the report?
Dr. Rajiv has left the meeting.
Oh, sorry. Then.
I think this is Dr. Jyotiman. So I think
Yeah.
I can answer this being part of MDTs. I've
Yeah,
seen medical
please.
oncologists take decisions. So if there is this doubt that one test shows a part of the tumor to be HER2 ultra low and another part of the tumor to be HER2 3+, the
Yeah.
medical oncologists would rather overtreat and would consider this case as HER2 3+ and treat it likewise. So
Okay.
hmm.
Thank you. Next slide, please. Yeah, this is the reporting as per the CAP 2025 2025 update. So I request Dr. Devanjan just to elaborate the main points. What should be there in a appropriate HER2 reports, so that the optimum treatment should be provided according to the CAP 2025 update. So Devanjan, please you elaborate the most important points here in the report.
Thank you, Devmaluda, for the question. What I see here is that in CAP reporting, that apart from the patient particulars, we have to put the test required, a number of blocks received, all those in very detailed form. What I am seeing, that date and time of the specimen collection, starting from the total the number of blocks we have to mention properly, and the formalin used 10% buffer formalin, time of fixation, type of fixation, and the duration of fixation, what time we have to fix the tissue, type of tissue processing, all those. After that, the result, we have to interpret it, the scoring properly, and we have to use the semi-quantitative scoring or discrete scoring, like the ASCO CAP guidelines 2023. They mention clearly that 0, 1, 2, 3+ like scoring we have to report, and the proper explanation of the each and every scoring. What we mean that for 0, what we mean for 1+, 2+, and 3+. And for that, we have to write in a detail, in a tabular form that you have mentioned properly, what we mean actually for 0 and what we mean actually for 1+ and 2+. What are the difference? What are the percentage of cells? And what is the complete or incomplete staining? Or what is the intensity of the staining? Whether it is weak, moderate, or strong. So everything we have to include in the report. And after all, and the low, ultra low, and null type, we have to clearly mention what we mean by low, what do you mean by ultra low, and what do you mean by null type? Because this information, particularly in the HER2 negative cases, is very, very important for the treating physician or clinical settings, for the medical oncologist to treat as whether they give is this ADC to this patient, and that will be, as you mentioned, a huge number of patients that is HER2 negative fall in this 60 to 65% of patients. They fall in this category. So whether this patient, we have to add a footnote that this patient may receive the trastuzumab deruxtecan as a ADC, and this may become beneficial for them. So starting from the patient particulars and from this top of the bottom, we have to clearly mention all of this as per the SCAP 2025 update.
Excellent, excellent, excellent. Thank you very much. So what we have inter discussions, if I make a very in a nutshell, that's HER2 is a very much important biomarkers current practice for the breast cancers, and binary pattern of reporting, there's a positive or negative is not enough now. There's a gray zone between low, ultra low, and everything. And for the appropriate reporting, the pre-analyticals, training of the pathologist should give them much more time to the slides for the entire evaluations, AI, digital pathology, and in future we are hoping for the mRNA expressions that definitely will benefit and reduce the subjectivity and this everything. So how the patient will be benefited by these new reporting format of the CAP 2025 updates. So everything we have discussed. Thank you very much for your valuable discussions, and to the audience also for their patience. Thank you very much.
Thank
I
you.
think
Thank you to our moderator and all our panelists for a highly insightful and clinically relevant discussion. As we come to the conclusion of today's session, on behalf of IAIO, I would like to once again thank all our faculty members for sharing their expertise and time, and our participants for their active presence. A special note of appreciation to our supporting partners AstraZeneca, Sun Pharma, and NATCO for their valuable support in making this academic initiative possible. We hope you found today's session enriching and relevant to your clinical practice. We look forward to your continued association with IAIO and hope to welcome you again in our upcoming programs. Thank you all and have a wonderful evening. Thank you.
thank
Thank
you.
you. Thank you very much.
so much.